Hi there, my name's Claire DeLeo and I've chosen Anorexia Nervosa for this presentation. It's identified as an eating disorder and mental illness where people have a distorted body image and fear gaining weight. They don't see the seriousness or reality of their condition, even though it's obvious to others. When the brain's starved of energy and nutrition, it doesn't really think properly. Those experiencing anorexia limit their food intake intentionally by eating less than their body needs and results in energy and nutrient requirements not being met and low body weight. They may eat less through severe dieting, fasting, exercising more, and/or forcing themselves to vomit or get rid of food through using laxatives. Some other signs may include making excuses not to eat, secretive behavior around food, or repetitive body checking behaviors like weighing along with low mood or anxiety. Statistics in Australia: approximately 1 million Aussies are living with an eating disorder in any given year. That's 4% of the population. According to the AIHW, in 2015 to 16, 95% of Australians hospitalised with a main diagnosis of an eating disorder were female, with women aged 15 to 24 making up the largest portion of these, around 57%. Similarly, the Butterfly Foundation and Eating Disorders Victoria reports that 2/3 of people with eating disorders in Australia are women and girls. However, Eating Disorders Victoria notes that men and boys are more likely to go undiagnosed because of stigma and misinformation. The Butterfly Foundation also reports that 15 to 20% of people experiencing anorexia or bulimia are male, though the actual percentage may be much higher because men's experiences may be overlooked or misdiagnosed by health professionals. This implies that statistics may be showing more females than they really are, since men are less likely to speak up or be recognised when it comes to eating disorders. AIHW has noted that in 2023 to 24, eating disorders are the third most common cause of burden of disease in young people aged 15 to 24 in Australia. It doesn't appear at all in the leading causes table for males in any age group. This following table tells us that eating disorders isn't fatal for the majority of those affected by it. Between 2018 and 2024, the years of life lost due to eating disorders in general increased from 243 to 790, indicating that deaths from eating disorders are occurring at younger ages, or more people with eating disorders are dying early, resulting in more years of life lost overall. Between 2018 and 2024, the years lived with disability increased from 50,000 to 55,000, meaning that either eating disorders are affecting more Australians or people are spending more years living with eating disorders. On average, anorexia starts around 16 to 17 years old, but increasingly younger children are being affected. Among adolescents, 55% of individuals with anorexia have had one or more coexisting mental illness at some point in their lives. Risk factors. The risk factors of anorexia can be divided into environmental and individual risk factors. In a systematic review, these environmental risk factors were families with high food intake, strict expectations from parents, family taboos about nudity or sexuality, low family involvement in a child's life, family conflict, family history of eating disorders, depression, other mental health disorders or substance abuse, having a sibling with anorexia, and maternal factors during childhood. Similarly, another systematic review also overlaps with the preceding, however also mentions triggering life events, societal expectations such as media forms showing unrealistic and edited images of bodies. Some secondary sources mention bullying from peers, trauma such as physical, sexual or emotional abuse or childhood trauma, being overweight in childhood, overweight parents, and participation in a sport where there is an emphasis on appearance. Some individual risk factors. A systematic review found individual risk factors that were common were perfectionism, emotional reactivity, negative affectivity, and another systematic review reported low self-esteem, body dissatisfaction, comorbidities of mental health conditions like depression or anxiety, and those aged between 14 to 18, and genetic predisposition. Some secondary sources reported extreme dieting and disordered eating, such as skipping meals or fasting and eliminating food groups, starting any diet in general, belief that thinness equals beauty and using that as a personal standard, emotional dysregulation, history of a mental health condition, concern about what others think, high levels of guilt, and difficulty coping with stress. Treatments. Some treatments include individual, group, or family psychology sessions, including CBT, DBT, or ACT for the person experiencing anorexia, GP visits, nutritional counselling to help eat well and reach and maintain a healthy weight, medication, and neuromodulation such as deep brain stimulation, repetitive transcranial magnetic stimulation, and VR therapy. Hospitalisation for those with immediate life-threatening physical deterioration, high suicide risk, or failure to progress in outpatient care. In-hospital treatment may include nutritional supplementation such as NG feeding and other strict monitoring following protocol. And another treatment is also family-based therapy. Pros and cons of the treatments mentioned. So medications, the benefits are that they reduce symptoms of co-occurring mental conditions such as anxiety or depression, or nutrient supplementation such as vitamins and calcium. The challenges in taking medications with anorexia are the side effects or the efficacy due to malnourishment. For neuromodulation, the pros are overall that it appears safe and well tolerated. Specifically for DBS, it may help in treatment-resistant cases. RTMS may reduce anorexia symptoms such as food restriction and anxiety and improve mood and cognitive control around food. VR may help consumers confront and modify distorted body image perceptions and may reduce anxiety. The cons are that there is limited high-quality evidence for the use of neuromodulation relating to efficacy and whether it should be used alone or alongside other treatments and how long the effects last and how they work in the brain. Current evidence available comes from small trials only. Hospitalisation, it's life-saving for those in critical condition, helping to stabilise them, though the challenges may involve consumers not willing to have treatment, feeling frustrated or that it's unfair, and hospitalisation can negatively affect adolescent development and may increase the risk of chronic illness. GP visits, they monitor and support overall long-term well-being. They also allow for early detection and prevention of any subsequent conditions as a result of the disorder. They can create referrals and mental health treatment plans for subsidised services. The challenges with both nutritional counselling, psychology sessions and GP appointments include the willingness to follow the plan, including attending any follow-up appointments and due to having fear of gaining weight. It may be overwhelming as well or stressful for the consumer, especially when they can't see that they are unwell. How does trauma interact with anorexia nervosa? Trauma has been shown to make eating disorder treatment less effective, increasing the chances of a longer illness, need for higher levels of care, treatment non-completion, and relapse post-treatment. People with PTSD, childhood trauma, and trauma experienced in adulthood are more likely to develop an eating disorder. Among childhood traumas, emotional neglect, physical neglect, and sexual abuse are the most common in eating disorders and occurred before their illness began. Bullying, teasing, and discrimination increase the risk of eating disorders. Minority groups such as LGBTQ+, migrants, or those facing racism have higher eating disorder rates due to stigma and social pressure. Even though PTSD is common among people with eating disorders, reported rates varied. One US study of 603 consumers found that 43% of people with severe eating disorders also had PTSD. This is almost half, though another review of 33 studies found a lower rate of 18 to 25%. Multiple studies also found that trauma was linked with more severe eating disorder symptoms and that it can worsen eating disorder symptoms. Therefore, it was concluded that treating trauma symptoms early may reduce the severity of anorexia. It's also possible that people with anorexia may become more sensitive to distressing experiences. Snug 206 has influenced my perception of anorexia and eating disorders overall by helping me realize that the media and television shows often influence people's ideas on mental illness and contribute to stigma. Stigma can lead to discrimination, possibly making it difficult to keep a job or get a job due to disclosing this to their employer, and can also strain relationships. Self-stigma may also deter people from seeking help or from speaking about their experiences. Listening to Tim Heffernan in Module 1 gave me a deeper understanding of these challenges and increased my compassion around this. He also pointed out the presence of stigma in mental health wards and services, which will make me more vigilant, and as a result, I'll advocate for consumers if they encounter poor treatment.